Overall, what are your thoughts on the keto diet, and then is it good for any one or any specific cancers?
We've been working with keto or keto adapted or keto-like diets for a long time. What we've seen over time and what I've seen working with people who are doing research in that area and collaborating is when we look backwards at patients that did the very best with whatever their therapies were, something that got them in the neighborhood, whether they were fully keto or a very low carb, non-insulinogenic diet, so keto-like, those are the patients where the therapy worked better and they had longer remissions or it stuck. And so what that said to me is, yes, I think there's probably cell types where it's probably better and maybe some where it's less of an issue. But what I tell people is I don't think that we know enough to say for sure, oh, it's only glioblastomas. That's, so that we have data on that, well, sure, okay, do it. But when I look backwards at the people who've had the best successes, they've been in that neighborhood with their diet.
Hey friend, welcome back. That was Dr. Paul Anderson, and today we're talking all things integrative cancer therapeutics. He's got a new great book coming out that's available now called Outside the Box Cancer Therapies. And I like this because it's really bridging East versus West. Traditional allopathic medicine meets integrative medicine. It's an awesome book. I think you'll dig it. And you can check out all Dr. Anderson's resources and websites in the links below here at Dr. A Online. And lastly, this episode is brought to you by you. People just like you are Patreon members. You can check those out in the videos and the benefits there at highintensityhealth.com/insider. Also, folks that have purchased courses from us over at courses.highintensityhealth.com, Keto Lean members, the Spring into Keto members, and our Fat Adapted Insiders. I'm super grateful for all of you. And I'm thankful that you're here. So let's dive back into it and talk all things cancer, keto diets, integrative therapies in the context of cancer with Dr. Paul Anderson.
Well, Dr. Paul, thanks so much for coming on. It's great to be with you.
Thank you for having me.
We've talked about doing this for a while. I introduced you at ShyCon, it was 2015, I believe.
Yeah, I think so.
So you've been lecturing all to practitioners. I mean, like you're on the road constantly.
I am, yes.
How do you balance that, knowing what you know about cancer, oncology, circadian rhythms? I would love to just start off the conversation with what do you do? What are your tactics when you travel?
I actually worked with somebody because we're usually our worst doctors, right? Yeah. And I hit a point, I mean, I've been traveling and speaking for 25 years, but I hit a point where the schedule was so busy that it was starting to take a toll. Mm-hmm. And I worked with somebody actually who used to commute east to west coast and had all these cool strategies. And so what a lot of it boils down to is the same things we tell our patients. What happens with people when they travel a lot is it's like, well, this is a travel day, so I'm going to not eat as great as I do, or I'm going to, whatever. You got to take care of the fundamentals. So eating well, and I do intermittent fasting, so sticking to my schedule is very important for that. That really helps a lot. Exercising, either depending on the schedule, either before I leave or when I get there, is super important. And then trying, even if I'm in a different time zone, to enforce some amount of sleep that's reasonable. And you can't always do it all perfectly, but the other thing that I do now that I didn't used to do very well is if I possibly can, I will schedule a recovery day so that I have time to not have a lot to do, work out, get back on the other time zone, and it does help.
Yeah, buffer in some of that time when possible. Yeah. It's hard though because that's more expense, more time away. But I definitely see the value in that. We just had Carrie Jones on, and she travels a lot too with the Dutch test, and she's like, I always have that buffer day, that transition. It's
made a world of difference, really.
Yeah. Let's dive into intermittent fasting, because you talked about how you're compressing your feeding window, and there's a lot of good research that was coming out. And Naisha talked about the study. I would love for your interpretation of that. Just 13 hours fasting. What did that do for breast cancer recurrence?
So it was really, it was really great to have those outcomes. Also great to have it before we wrote the book, because then we could include it in the book and tell our patients. But the short version of it is, with a 13-hour window of not eating, you do, water and non-caloric liquids, but no eating. with people who had survived breast cancer once, about a third of them actually had less, who did the intermittent fasting had less recurrence. So a third less recurrence, which is, I mean, there's not very many things that do that across the board. And the more I looked into it, and I was looking into it for the book and for our patients, but also for my own health, there's all these different strategies. There's the intermittent fasting around chemotherapy, which is very effective. And we get into that in the book, and that Dr. Longo and his team really did a lot of work there. It's actually one of the diet interventions that is done in hospitals, one of the few that's actually been accepted and kind of done in hospitals. But what we found is even in our non-cancer patients, their biochemistry will change after about 3 to 4 months of doing intermittent fasting, even 13, 14 hours, where their blood sugar control gets way, way better and way more level. A lot of their inflammatory markers will go down. Things that will trigger cancer and trigger other problems, which is probably why they had more survival in that group.
Interesting. Yeah. And you noticed yourself, your hemoglobin A1C dropped dramatically, you said?
Yes, yeah. It was, I was actually shocked. I did all this baseline stuff, and it was just sort of an interesting experiment that I wasn't thinking I was doing, but because of the travel and all that, I had kicked up my exercise and I had cleaned up my diet more and all of this stuff. And both my grandfathers died of diabetic complications, so I got a little bit of the genetic lottery going there. And I was still trending up, and it was like, and so I started reading Longo's work and everybody else, and I'm like, I'm just going to do this. Yeah. So and I tell this to patients now, it's more of a mind game. I did 12 hours first, and then I add a little bit. When I did just the diet change and exercise increase, my labs really didn't change a lot in 9 months. And then I went to the intermittent fasting, and in 4 months, my A1C dropped down to completely normal. It dropped about 8 points, which is kind of unheard of.
That's amazing.
All my inflammatory markers went down. The thyroid dose that I needed was almost non-existent afterward. A whole lot of really good stuff, and lost a bunch of weight and all that. I feel more clear. I can work. I don't have any trouble working out. I'm a huge fan. Now it's but it was, I gave myself a couple of weeks at each stop to get used to the idea of it, and and then most of your side effects are dehydration because people just don't drink enough fluids.
Or psychological, because people have been taught for so long that they have to eat, like stoke the fire in their metabolic rate, and
breakfast is the most important meal of the day, and then here we tell them, well, you're not going to eat breakfast till later.
They're like, people are confused, and I think it's hardwired, like in myself, because I kind of come at this from a fitness background, and I remember like you always have to eat breakfast, so it's taken a little bit of a shift. But going back to what the hospitals, you said they're embracing intermittent fasting around
chemotherapy. It makes sense because the studies that they did were hospital-based studies, and they were so compelling, and also it kind of matches the patient experience of they really don't want to eat during a particular amount of time, and so there's a particular time where they stop eating and just hydrate, around their chemotherapy. And then they have a particular window right after where it's just fluids when they really aren't feeling great anyway. And then they eat, and they actually feel like when they break the fast that actually they're about ready to start eating again. And just by doing that, that's also increased quality of life and some of the chemotherapy side effect outcomes and things just by doing that. And I think what they're seeing is when people start to do that, then they start thinking, well, maybe this other thing of doing a 13 or 14 hour window where I don't eat, it's not going to be that hard, So we work with people where they're at, but one of the things that I've found, and really everyone you probably talk to says the same thing, if they practice more than 5 years, our message to people is that all the natural therapies and integrative things and all that we do with cancer or other chronic illness are wonderful, but if the body they're going into is not being taken care of as well as it can, the system, it can only do so much with kind of a miswired system. And diet and sleep and exercise and how you're thinking and all of that that's your that's your base.
I think that's an important message, because the mass action of you take a drug, PPAR alpha agonist, whatever, phenofibrate. Take a drug like that, like it's so specific for blocking that one pathway that if someone is not doing the dietary changes, it's still going to block that. But what I heard you say is, like, if you just dabble and take curcumin, but you go to McDonald's, that you're leaking. There's not. You're not going to know it's a difference. So that's kind of the thing that it's. I think unfortunately, natural medicine can sometimes get a bad name because people are not doing all the integrative stuff. But the lifestyle things, the foundation is not strong enough.
And it's like every year I'm practice, it just becomes so much more obvious that the people who do better, you know, the longer you practice, the more people you see, the people who do better are tending to the basics on top of the other stuff they're doing. And it is different. It's like, you know, we come from a mindset, most of us grew up, you know, in kind of the standard medical system. Well, if you got strep throat, you got an antibiotic and it seemed to kill it. It didn't matter what you were eating or, you know, whatever went on. If you get a chemotherapy, it does what it does regardless almost of what you're doing with the rest of your life. Natural and integrative therapies do a little of that, but more of what they do is work with what you've done with the rest of you. So it becomes, you know, with patients you can't be judgmental about it, and, you know, if you're changing their whole life in 1 week, that's tough to do for some people. So we start and say, look, start here. How much of this do you think you can do? And we'll build on that. But, you know, we've got to get you sleeping on a good schedule. We've got to get you, even if you're really, really tired and ragged out, we've got to get you moving your skeletal muscle a little bit every day. And if that means walking around your house once, great, we'll start there. We've got to get you hydrating, because none of us do that anyway. And then whatever we're doing with their diet, you know, we start and do baby steps towards that. Because they will come, like all of us, it's human nature, they'll come and say, well, you do these really cool, you know, IV therapies, or you do this stuff with mushrooms, or whatever it is. And we'll say, yeah, we do that, but that's the icing on the cake that then will take your body and make it do something. The rest of it, you got to get your body ready to do that.
That's a brilliant point. I love that message. I hope people share that message because it's really powerful. You brought up chemotherapy a few different times. The analogy that I've been taught about how chemo works is, well, first of all, is chemo now specific enough? Do we know? Or is some of it kind of like, well, you have this type of cancer, we think it's going to do this, and then what happens to the cells that aren't killed? Do they come back? Is it like that weed that just doesn't go away and it comes back stronger? Is that?
Yeah, that's, so I'll break that down a little bit, because there's a number of concepts that are great there. The first thing is that probably in the last 10 years, but especially the last 5 years, there's been more evolution in chemotherapy approaches than there were in the previous 50 years. So we used to have cytotoxic, we still do have cytotoxic chemos, which basically indiscriminately kill cells. Okay, so, and they, of course, they were targeted at rapidly dividing cells, but we have a lot of rapidly dividing good cells too. Then in the last decade or so, plus or minus, targeted therapies have come out, which can be really good, and sometimes are mixed and matched with the old therapies. But, you know, what everyone sees is the targeted therapies are this bridge between kind of the older therapies, which we still use a lot of, and by we I mean the larger group, and then the targeted therapies, we're trying to figure out what the best way to use them is. Because what happens sometimes, and I'm going to be doing actually 6 hours of lecturing to physicians on this coming up in July or August or something, because it's so complex. The problem that goes on is the old style stuff indiscriminately went in through 1 or 2 mechanisms, just blew cells up. That's a simple thing. Targeted therapies go in, and we have all these cytokines and cell triggers and receptors, and it may go in and just push on 1 of them or 2 of them or a little family. So that looks great on paper, but what happens sometimes is you do that with a cancer cell and it says, well, we can't express this way, but we have 200 other ways we might express. So there's this really wide divide in targeted therapies where some are life-saving and work really well, and some are now being associated with either deadly side effects or cancer coming back stronger. And it's not necessarily that targeted therapies are the best we can do with biological medicine now, but it's that I think we understand a portion of the biology that we're messing with, and we don't understand the part that kind of comes around and bites us. And something that we talk about a lot in the book, or at least in chapters I wrote, because I'm all about it, is there's kind of three major ideas or theories about, well, why do cancer cells propagate and all this stuff. So you've got, metabolic, which is huge and it's on the rise, and that's probably a core. The genomic part is really more epigenetics, which is lifestyle and toxins and stuff like that, which does happen. And there's a few cancers that are truly genetic, but most of them are not. But then there's the other, which kind of grew out of so the metabolic theory's been around forever. There was another one that they used to call trophoblastic theory that was kind of pushed to the side, and it had to do with cell biology, but was our understanding of cell biology like in 1920. So, it was outdated science and no one really updated it, although they published something about it in 2015. And what they were saying was, we have this new theory that is kind of a modern science rendition of the trophoblastic theory. It's called the cancer stem cell theory. And that goes back to like the weed that won't go away. And what we know now, and it's published multiple times a year, and the publications since 2012 have just keep coming, and we mention a lot in the book, is if we do a great job with a chemo or something and we kill the main tumor cells, the cancer stem cells will take a step back because they're survivor cells, and they'll just wait. And the cancer stem cells will often be the thing that 6 months, 1 year, 10 years, 20 years will come back, and either as the same cancer or a little bit of a different twist on that cancer. And they'll actually be emboldened by the standard therapy. And when they write these papers, and these are major, scientific journals, when they write the papers, they all end the same way, saying, well, we don't want to scare people, but this is the truth and we see it. And their answer is, well, what we need is more targeted therapies to find a way after these cancer stem cells. Well, what we talk about in the book a lot is, that'd be great if we, but that might be 50 years away before they figure the cell biology out. When you look at it, and I've been lecturing about cancer stem cells and keeping them quiet for a long time, it honestly goes back to, you can have all the cancer stem cells that you want, and we probably all have some. If the basics we talked about are level, and if your inflammatory milieu in your body is not being pushed on all the time by weird hormonal things or blood sugar shifts or all the other things that inflame us, toxins, etc., the more you do to keep that quiet, the less those things will come back. And we do this a lot with patients. One of the areas where we'll actually, things that have changed in the last few decades, we may get referrals from oncologists now about that we wouldn't used to, would be secondary prevention. So somebody comes and they say, I had X cancer, my oncologist says there's no evidence of disease. They said, go and don't have cancer, come back if you get it again, but we don't do that next step. So they'll come to us, and really what we do with those people is, it's awesome, great, let's keep that cancer away, but what we want to do is not have your body have any reason to restart the process. And then we look at things, beyond their diet and lifestyle and all that, which is the core. Many of those people, probably because they've had cancer treatments and their immune system got beat up, have immune issues. A lot of them have some nasty chronic infections that like to live in the lymphatic system, which will restart cancer. A lot of stuff you can deal with, sometimes toxic things, sometimes hormonal aberrations, because what happens when you're being treated for cancer is every other medical problem you have doesn't exist to anyone because you have cancer, right? And so,
in a silo.
So yeah, and it's like, well, let's get the cancer taken care of, and then someone else can fix all this stuff later. Sure. And I can't tell you how many people with breast, prostate, colon, some of the more common cancers will come in, no evidence of disease, which is awesome. But we might find like 5, 6 things that are very treatable that need to be worked on. You don't want to take somebody who's been through that cancer journey, let those things smolder, because those are all the things that go and poke on the cancer stem cells. You know, diet too. I mean, a lot of stuff that you got to work on.
Yeah, I definitely want to revisit the cancer stem cells, but if I don't ask this now, I'll totally forget. So it seems that cancer is almost like an organism that maybe has a purpose or something. I mean, how is there some innate intelligence of the stem cell to like using your vernacular, to pause and wait and then evolve, or, you know, kind of have these mutations to outsmart these targeted therapies? I mean, have you ever thought, like, gosh, what is this? Do we know, or is that a little out there?
It's definitely not out there. I have colleagues who are way into that discussion, and what I learned from listening to them is that we don't really know, but there is this organization to the way that cancer works, and some people have the thought, well, that organization is just a natural outgrowth of a survival mechanism, which makes sense. Where they go next with it is, you know, different directions. It's a survival mechanism because we are now weakened by toxins, or we're weakened by whatever. The next steps really go into great things to debate about and all that. But definitely, if you look at that collusion of those three main ideas around cancer, so genomic things, which really turn out in the main to be weak genes that get epigenetically banged on by things like toxins or diet or lifestyle or whatever, that happens. The metabolism really goes back to, are your mitochondria happy, doing the right thing? Are you cleaning the cell junk out? All that stuff. If that's not being tended to for long enough, that triggers these things to go. And then there's the stem cell idea, which is very well, you know, supported, but it's the same thing. All of those things are aggravated by the stuff that weakens the human organism. So I think it's at the very least a survival mechanism for these aberrant cells, and they're just like, they just have a great place to, a great host.
A great environment to thrive
in. And our environment is getting more, you know, more amenable to it, I think. I think that's why we see higher cancer rates and things. We have more, just, if you look at the Endocrine Society's endocrine disrupting chemical report, comes out, it's never a happy thing, right? But
scary stuff.
2015 was the last one, and it's like, their message is it's worse than 2 years ago.
Yeah.
And you just like keep reading, and it's like, wow, you know, like a baby born today is more toxic than its parents will be, and more toxic than its grandparents could ever be. Yeah. Well, I mean, we just live in an environment where I think what it says to us is, yes, we can lower our toxic, well, we need to do that, but we can't avoid everything. So that means we have to be more careful about how we, you know, how we tend to ourselves and what we do to, you know, keep things going. So I think that cancer just has an easier time nowadays.
The environment's more favorable to flourish and whatnot. You know, I asked about that because Herbert Benson work, I think he's at Mass General. He wrote the book, The Relaxation Response. He's really big into the field of psychoneuroimmunology, endocrinology. And so is there a common theme in your patients that you found where maybe there's some negative self-chatter, mental chatter, self-loathing, lack of respect? I don't know, I mean, these sound like kind of woo-woo things, but if you're constantly saying poor messages in your mind, you know, we know that aberrant thoughts affect the immune system.
Yeah, I think now, if we're having the discussion 10 years ago, it might have been more woo-woo, but I think now that's reasonably accepted, that those sort of things affect your neurobiology, your endocrine system, and it's one more little dig at the system. You know, it's kind of like not exercising, or it's like eating horrible or whatever. It's just a dig. And I think an important thing that I've seen, you know, going on, you know, the third decade now working with cancer patients, it's like every bell curve. There are some people who have done absolutely everything correctly, have lived as clean a life as possible, everything, and they get cancer, and maybe it's an aggressive one, and it and their brain is great, everything's working great. You see those people, and it's like, you know, they just like, man, those tend to be triggered by probably deeper, stronger things. And we see this with some pediatric cancers. We do a lot of work with kids with cancer, and the ones that really just get like they haven't been alive long enough to get too toxic and all this stuff, and they're doing everything. But then there's the middle of the bell curve, which really you see kind of a couple of neurological groupings. One is what you talked about, which is the things that would kind of bang on the psychoneuroimmunology and just, it's like every day it's kind of just pulling you down a little bit, right? Yeah. And you could maybe extrapolate that eventually your body says, well, if we really hate ourselves that much, we'll do something with it. So there's that. Then there's people who I think trigger it a different way, where maybe they are not having tons of negative self-talk and stuff, but they're also not having tons of good self-care habits because they're hard charging, they're getting stuff done, and they're all about themselves and how it's going, but they're beating themselves up a different way. So one of the things that we've found is on the front end with people, we try to be sensitive to that, because you imagine, like, if you've been in a negative space a long time, beating yourself up, and then you get cancer, that brain is going to go to a really dark place, with the cancer diagnosis. And so you have to be careful not to, say, well, your diet's bad, and you got to have a kind of a positive message to move that along.
Sure.
But what we find is we actually have very specialized mental, emotional psychiatrists, psychologists, people that work with chronic illness and cancer specifically. And because that's such a profound area for that group of people on that front end of the bell curve, we connect them, because that's just as important as their diet change and everything else. They got to get this straightened out. Yeah. And it's if that's gone on for 40 years, that's a job,
It's going to take some time with meditation or Tai Chi. I mean, the real spiritual work. Yeah, that's amazing. So definitely want to get back to the cancer stem cells and help us better understand. So I've heard of like mesenchymal stem cells, right? And we have adipocyte stem cells. So talk about like, what is a stem cell? What does it do? Life cycle, and then how is a cancer stem cell different?
Really, a stem cell of any kind is a more primordial cell that has multiple potentials. So it's actually, so if you go back to like an embryo, the reason we can come from, 2 cells and be a zygote and all that, and develop limbs and everything, is because these primordial cells develop into different tracks, and then they get more specific and more specific. And then we lower the amount of that as we get older, and we have just little bits of stem cells that help us with healing and repair and stuff. So we keep a few around. The cancer basically works on the same format. It's like, well, we're cancer as an organism. We're going to have some of our cells that are going to stay with the blueprint, and then we're going to have kind of the soldier cancer cells that are going to be what we see. So if it's a solid tumor, that's the solid tumor, the metastases. If it's like a hematologic cancer in the blood or in the lymph nodes, it's different, but same idea. But the stem cells are partly, and there's a lot of, again, some of this gets to conjecture about, we don't know exactly why they're there, but the stem cells are really there to protect the organism. In this case, it happens to be cancer. So they literally will be unaffected largely by the treatment that will knock out the soldiers. And so they will hang out. And what the data is showing now is that the harder we hit the soldiers with something like chemoradiation, that's a very, it's a cancer cell toxic therapy and toxic to the rest of us too, the more the stem cells back away. It's sort of like, you guys go fight. We're gonna go over here and just kind of hang out. And they actually have the ability to recruit normal cells, which is one of the reasons why cancers can go, you have your 3rd recurrence or something. It's like, man, didn't we kill it all the first time? So they actually, in their biology, are set up not to go out and multiply like crazy and metastasize like the other cells. They will go, and then they will go park somewhere, maybe the same tissue, maybe a different one, and they literally chemically will recruit the normal cells around them to become new cancer cells. So those share information, chemistry, etc. It's not a happy thing to think about, but it's scientifically fascinating that these cells are that good, like that they can do that. And so when it comes down to it, and since we don't have a zapper that says, you know, this will kill all cancer stem cells, the end game right now is keep them happy and quiet. Like don't have them have any reason to want to recruit anybody.
Yeah.
Okay. And so when I first started speaking on this, I was doing a presentation at a hospital which did a lot of integrated therapies, and they really wanted to know about it. And when I was done with the presentation, it was like they really wished these didn't exist, because it was like everything we do to kill the other cancer will make these stronger. So that means you have to follow your patients afterwards and tell them these guys are going to be there. Your world and the way you treat your body and maybe the stuff you take or whatever you're going to do has to be swimming in a direction to keep them totally quiet and non-excited. And that's, I think, where the crossover, and thankfully the editors let me leave it in when I was doing I did the 3 kind of main theories of cancer. What I tried to do there was actually say they're just looking at the problem from different angles. So just because you have cancer stem cell theory doesn't mean the others don't work, and metabolic doesn't mean the others don't work. But if you think about it, the metabolic thing is probably such a huge thing, because that's largely what goes on in our chemistry every day. That would, if the metabolism is towards inflammation, it's going to bang on these guys, and they're going to say, well, let's recruit some, you know, cells. Kind of like if your metabolism is not balanced and your insulin, your sugar are all over, and all that inflammation, you know, your epigenome gets triggered and maybe something goes on. So I think that's why the dietary interventions and moving your skeletal muscle and all that stuff that makes our biology cleaner is so important, and it's good for all 3. So you can't lose, right?
Good on the prevention side.
On the
good,
prevention
and then
side,
on the preventing reoccurrence
preventing reoccurrence. Same.
It's a key point to and one of those lifestyle modalities or nutrition metabolic modalities that you spoke of is a ketogenic diet that has gotten a lot of press. You know, there's some naysayers saying, well, it's just, you know, cell type specific, maybe neurologic cancer, or maybe breast or prostate. Overall, what are your thoughts on the keto diet, and then is it good for any one or any specific cancers?
We've been working with keto or keto adapted or keto-like diets for a long time, and as you know, they weren't terribly in vogue, and there's still a lot of, you know, a lot of pushback on them. But what we've seen over time, and what I've seen working with people who are doing research in that area and collaborating, is when we look backwards at patients that did the very best with whatever their therapies were, something that got them in the neighborhood, whether they were fully keto or a very low carb, non-insulinogenic diet, you know, so keto-like, those are the patients where the therapy worked better and they had longer remissions, or it stuck. And so what that said to me is, yes, I think there's probably cell types where it's probably better, and maybe some where it's less of an issue. But what I tell people is, I don't think that we know enough to say for sure, oh, it's only glioblastomas. That's, you know, so that we have data on that. Well, sure, okay, do it. But when I look backwards at the people who've had the best successes, they've been in that neighborhood with their diet. And one of the things that we, you know, and it's a big change for someone who didn't know they had cancer. They're 55 years old. They've never eaten that way. Now they've got cancer in this weird diet you're telling them about, you know, to try and deal with all at once. Yeah. So we do walk carefully into that. But the other side of it, and this is something, Dominic D'Agostino and I did a conference together, and we were collaborating. One of the things that he and I brought up on a panel that he was saying is something in the U.S., it's very American of us to do this. It's like when you do a keto diet, you actually take it too far, the American way. And he says, you know, in most of the rest of the world, they still eat a lot of vegetables. It's just the vegetables they ate don't have a lot of carbohydrates that are convertible. And he says, so they actually have they have more flavonoids and fiber and all that stuff. So we really try and work on that with patients and say, you can't just start eating fried chicken or whatever,
butter and bacon.
Dipping your butter and bacon. There's a healthy way to do this, and the last thing we want to do is, again, give the cancer or the stem cells any impetus to do the wrong thing. So we do try and do that with people. Now there are people who, for various reasons, they can't do that. So what we'll do is we'll modify, and we'll do what I like to say a high raw and modified raw vegetable, low glycemic diet with MCT oils and a lot of good fats that are kind of added in that they can do. And another thing that he was talking about when we were doing our thing was there's now vegan keto approaches and all this. You can modulate it. I would say the people I've seen with really long remissions, many of them have been in the keto end. The other thing that we saw, so I refer to research, so I was for 5 years involved with an NIH-funded trial looking at integrative cancer therapies and would it extend lifespan in people as compared to people who just did standard therapy. And what we found is it did, and that data is being published now and all that stuff. But the other thing is I started to be able to experiment with different therapies, and one was a metabolically oriented therapy where if you didn't do the diet intervention, basically nothing happened because the therapy was metabolically approached. So we actually have a grid in the book that they did, and it's very clear it was a group of, I think, 15 people on the beta. There were people who had disease regression or paused their disease. There were people that still had disease but improved quality of life, and then there were people who had just had progression. And when I look back at it, everyone who was in the progression side were the people who refused to change their diet.
Wow.
It's not 500 people and all that, but it was like the only thing in common with these people in this category was they were the people that refused to change their diet. The people over here, what we were doing is we were manipulating the cell's metabolism in a way so that if the diet was changed, it kind of closed these doors. The things we were adding kind of closed these doors, so the cancer cells became weaker. Well, it's kind of like we said about targeted therapies. If I just close these doors, your diet's not very good and inflammatory, the cancer is just going to pick these ways to go crazy. And that's what I believe we saw from that. So we're big fans of keto or the keto neighborhood, but we do understand sometimes there's, we have to do the best we can with what the patient can do.
That's awesome. I'm excited to read that part of the book and then that study. So is it that our immune system is weakened, or is it the cancer, we're giving the cancer more tools? I mean, just as a big picture, I mean, I know there's context-dependent applications, but if you could just, someone in an elevator asked you, what would you say?
On the side of why are we probably seeing more cancer incidence with people, it's probably more we've got all these little things banging on our immunity and our resistance. So the pervasive toxic milieu we live in, the not great diets, the circadian disturb, all that stuff. I think when it comes to cancer coming back and cancer being very resistant to treatment, that's all that stuff, but it's also the fact that the cancer stem cells, the more we do with the original cancer, the stronger we make them, and so then we get recurrence. And the question that's open right now is we're pretty clear, and actually put it in a couple of the chapters about prevention, et cetera, because I think it's important people know this, even though it's kind of a downer topic. We're pretty clear that the standard cell-killing therapies are what really strengthen the stem cells. So the mainline chemos and radiation, that's in the data really hard. What we don't know is if these new targeted therapies are sort of a neutral issue, or because they're targeted, does the stem cell say, well, you push there, you know, I'll get stronger over here. And I do think that that goes on, certainly with basic chemo and radiation. We don't know about the other stuff.
Well, it's a scary situation to be in if you're a patient, hearing that, because you're here diagnosed with maybe a nearly fatal disease. Right. You only have a certain amount of time to live. On one side, you have all these integrative therapies that in conjunction have never really been studied. So you're like, well, I'm not really sure here. And then I have this, you know, similarly with the chemo. So it leaves people going, maybe making emotional decisions, you know? It's
another thing about managing the mindset, because you do have to understand that this is like one of the worst things a person can hear. And there's a lot of like fear and baggage obviously that goes with it. So you don't want to play into that, although you have to honor that it's there. You may, you know, and a point I'd really like to make, which the book makes a lot of, but just to say it out loud, we talk about integrative oncology. Even though we're naturopathic medical doctors, we talk about integrative oncology because our way of practice, Mark and I both, who wrote the book, has always been integrative. And that means that if you come to us and there is a 95% success rate with a standard therapy for your cancer, whatever the standard therapy is, surgery, radiation, chemo, we will say, look, do that because it's got 95% success rate, but let us take care of the rest of these things. Don't just, it's not an either or thing.
Right.
There's also, like, just to go way the other end of the spectrum, there are people, well, you know, and nowadays a lot of oncologists will literally say, this has got less than 5% chance of helping you. I don't think I would do it as a doctor if I had your cancer, because I know you'll get the side effects, but I don't know if you'll be in the 5% where this is going to help. And they're more likely to say, you might want to try integrative therapies because I don't know if that'll help either, but it probably won't harm you, you know. So I think that's because cancer is not one thing, it's in this spectrum. Our bodies are not all the same and we deal with cancer differently. Each patient's case has to be assessed to say, when's it appropriate to do a standard therapy or a group of them? When's it appropriate to do integrative things? And then more importantly, if all that junk that we did works, how do we not have this come back? Which is really, that's the main, you know, end game there. So yes, you have to, and you know, a lot of people, their first diagnosis, of course, is at the oncologist's office. Well, the oncologist knows what they know, and then they do it really well, and they'll say, well, this is what we do for your kind of cancer, boom, 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 let's just get you going on it, you know. And they may not actually have the discussion of, well, this is what we do, but it works in 5 or 10 or 20%, or it works in 95%, you know. And so we always tell people, look, take 1 or 2 people with you because they'll hear it different. Ask about, you know, for my case, in your experience, is this something where I've got a pretty, you know, better than 50% chance with what you're going to do, or is this kind of an experimental thing? And we do see that a lot with people with recurrences where the oncologist, for very good reasons, they know what they know, and they will say, well, we have a 2nd or 3rd or 4th or 5th line therapy. It's experimental. We've seen some people do well, some people not. And the patient will take that as, well, that's the only thing I can do, let's try it.
Right.
Sometimes those are the times where the side effects, you know, may be what do the patient in, as, you know. So what we really try and promote is there's no one answer, there's no one patient. So do your best, whichever parts of the medicine work the best. Work with people who know, you know. I don't prescribe people chemotherapy. I leave that to people who do that really well, or radiation. But I know how they work, and I know when they work well, and I know all the stuff I do. So work with at least 2 sides of a team who can put those together for you.
I love that approach, you know, because I think in our integrative natural medicine field, allopathic remedies get poo-pooed regardless because they're drugs. You know, we had Tommy Wood on, I don't know if he's just in Linwood over here. He's an MD PhD out of the UK, and he talked about the benefits of metformin, and a lot of people jumped in on the YouTube comment and said, I can't believe this doctor said metformin is good, it's a drug. So they hear drug, they think it's bad. But like you're saying, is you need to look at the, the risk versus the reward and specificity.
This is coming from trying a lot of different things over all these years, and trying, with people would come in and not want to do any standard therapy, or only want to do one in integrative therapy or whatever. And when I was younger, I might buy into that and try it. What I found is, whatever the tool is, if it's good for the point you're at and it helps you, whether it's a drug or a natural thing or whatever, do it in its context, do it safely, and then there's all sorts of stuff in the natural medicine world we can do so it doesn't hurt you, or whatever. And again, it doesn't, it doesn't mean that chemo is for everybody, and chemo certainly has a lot of downsides, but there's also times where it probably is, appropriate. And I know, because people, as I speak a lot to doctor audiences, it's really interesting to get different audiences of physicians, because I'll say the same thing about integrating and use the best of both worlds. One group will take that as, oh, you're just doing all this hippie, weird, woo-woo stuff and whatever, and you don't like our chemo or whatever. And the other group will take it as, oh, you let your patients do chemo, that's horrible, and it's like, well, I don't do chemo with everybody, and I don't do, it's really, so you get beat up no matter what you say to people.
Totally. I can see it. It's amazing. Like, if you mention, like in the keto world, you mentioned carb cycling. People are like, you're promoting carbohydrates? No, we didn't say that. So people just, it's crazy what they hear.
Yeah. So it truly, I can't say enough that, like, if you come to me and you had a twin and you both had the same problem, literally there could be two different treatment protocols, because let's say it's cancer, and I tell patients this, especially, chemo and radiation do what they do, but all the integrative things, they work with what your body is doing right now, which is why we're so big on diet and all those other things that they need to do. But the other thing is that I can have two 55-year-olds with the same exact cancer, and they appear to be about in the same place. You do the same therapies, and one thrives and the other one it just kind of bounces off of. And it goes to the idea that whether it's a metabolic therapy or an immune manipulating therapy or any of the other things that we do, if your body can't work with it, it's not going to be as successful. So
it's a great point. Yeah, and just individualizing everything. We're all different. Let's kind of finish up a little bit. We're talking offline about some kind of pre-screening, getting out there prophylactically. As people, what I've been told is cancer is a disease of aging, right? I mean, outside there's some outliers, early genetic issues and stuff, right? What are some tests? You mentioned LDH, what are some things that, like, if someone maybe has high risk, you mentioned your family, their diabetes runs in your family, let's say cancer runs in the family, what are 3 tests or 4 tests that people should do?
The problem that comes is, by the time we can see a cancer or a tumor with most imaging that we have and stuff, which is way better than it used to be, so that's good. But by the time we find it, it's probably been growing, usually slowly, for 5 to 10 years, maybe longer. And the reason is that it starts literally with the one little maybe cell or stem cell group, and it just stays small, and then it kind of waits for insults to get bigger. So the issue right now with pre-screening is, we have, certainly if you feel something, you've got imaging, and that's better than it used to be. But then that's maybe a 5-10-year-old problem you had. There are some pre-screening type tests, and they're getting better. So most people know about tumor markers. So they had ovarian cancer, they do a CA-125, which once you know you have cancer, you can follow. It's not a good predictive test, though, because if you have Crohn's disease, it'll be high. If you have other problems, it'll be high. So the old tumor markers, PSA is like the classic example of this. Like, gee, we were following PSA, now we were over treating, stuff, So the tumor markers, they're the best we could do. The next generation, and then I'll come back to like some of the other things. The next generation is more, can we find things like circulating tumor cells, which is a big area that the Europeans led in, and now there's actually better and better technology in North America. As we were talking offline, I was saying back, so we're going back eight years or so in the research project, we were using the early cancer stem cells that were available in the US, and they were cool to look at, but they were completely unreliable. So you'd have people with high stem cells who didn't die and no stem or circulating tumor cells, high, and they would have no disease you could see, and then there'd be no circulating tumor cells and they'd be dead in a month.
Yeah.
That was
all over the place.
That was not really helpful.
Yeah.
What we see now is that technology, everyone's all about that technology. I mean, the whole world, the regular oncology people, everybody's about it, because what they're saying is, if we can do this for screening, that'd be great, because we could find it at the cell level. And then if we could do it to follow your disease, much better than a tumor marker, which takes time to rise. So that's really the kind of the hopeful direction things are going. There's a few genomic tweaks there that are pretty good to look at. Mm-hmm. In the middle, while we're waiting for that technology to get better, and you probably talked to Nation Winners about this too, there are some tests that have been around for a while that we do the technology, we can process them better, that look at your metabolism shifting towards either an inflammatory milieu or a milieu that's showing, toward Warburg Effect or something like that. And they're basic things that we've used for other things. So like alkaline phosphatase, lactate dehydrogenase, CRP. There's a number of other those, and they're called non-specific inflammatory markers. But if you follow those in people and they're trending up, if they don't have a reason for it, like an injury or an infection or whatever, you have to start to say their body is doing something that is chemically very inflammatory. We need to figure out where it is.
Sure.
So there's that. And then there's another group, equally useful, where they will ase other markers, and these may be only in certain tumors elevated, but they'll do a panel. So alpha fetoprotein and beta HCG, which is the pregnancy marker, but it turns out that goes up in certain tumors, and a number of other ones that they do. So while we wait for circulating tumor cells to get really, really dialed in and good, and whatever they're going to do with that, we're using them now, but it's like there's still gaps. We do these other markers. There's also some predictive markers that I've seen. We talked a bit about offline, but there was a test called OncoBlot, and then it's being reformatted into a better technology that a lot of people that I have worked with that do integrative oncology have used, and if it's positive, it gives you a target to go and say, let's image this area, or let's at least redo it in 3 months or whatever. So there's some newer things. There's also some biologic markers like TK1 and a few other kind of high-speed things like that. Again, lab tests are based on our understanding of science, plus our ability to do the technology to make the test work.
Yeah.
Because that was my previous career, was in labs, and so the same name of a lab test from 10 years ago may be a completely different marker than it is now, because we know more about the science and the technology works better.
Yeah.
So I have a lot of hope for lab testing and early diagnosis, and also predicting recurrence, which the sooner you get after the recurrence, the better. But we're really on the upswing with that.
Interesting. Yeah, the alpha fetoprotein. So I kind of had some pain around my liver, so I tested mine, and mine was high, and now it's brought me down this rabbit hole. So that's why I was kind of curious. I didn't look at LDH, but I have a lot of doctor friends who are, like you said, with the CA25, who are like, this is not necessarily a good predictor. We usually follow it after the fact, but anyway, so I was just curious.
And that's the one caveat that I always tell people is the real basic ones that are not at all tumor specific, like LDH and CRP and alk phos and stuff. if you get a suite of those and they're all trending up and they keep trending up, you got to go do some digging. You get like a HCG or alpha-fetoprotein or something like that. It can be elevated for non-cancer reasons, just like CA-125 and some of the other cancer markers. So then you have to dial back and say, okay, I have this elevated value. Could it be that I'm, you know, there's a metabolic reason for it or something?
Sure.
So what we always tell people is, you know, a tumor marker, a non-specific marker, whatever the test is, one data point is just that. Then we have to pair that with how is your body working, what other workup we do. We'll do some treatment to bring down, you know, the metabolic load and de-inflame them. If we redo the test and it's back to normal, that's not cancer.
Right.
You know, I've had that with actually with family members. I did this suite of tests on this family member that was losing weight and kind of had some of these cancer signs, and it came back, and you know, the CRP was like through the roof, and there's all this stuff, and I thought, ooh.
Yeah.
And so what I said was, let's give this 12 weeks. Let's put together a program where we're going to shift your diet a little cleaner. We're going to do some things for, you know, this could be like orthopedic inflammation or other stuff. They're about the right age. And the proof is, you know, you do that follow-up at 10 or 12 or whatever weeks you're doing. If it was still high, well, then we're going to do imaging and we're going to go on. In her case, it all went back totally to normal.
Wow.
And it was like, looked totally like cancer. So we do that a lot where there's not an obvious reason to image the person right away or whatever. A treatment trial that would, you know, do it. And what I always tell people is, hey, if it's cancer, it's not going to go down and be falsely negative.
It's going to keep increasing, right?
Yeah, if it's not cancer and it's one of the 11 million other reasons that it can be high, it'll go down. And then, you know, we'll just keep an eye on you, but we're not going to worry after that. So it's, you know, that's the state of the art now. I'm truly hoping for, you know, we're going in great directions with tests, but I think we're still a few years away from really good ones.
Well, yeah, and if I heard you correctly, I mean, looking at some of the basic metabolic markers, I think is great. And so, but the trick with that is, you know, some doctors weren't trained to say run GGT. They just run AST and forget ALT. So you need to be your advocate for your own health and say, no, doc, I want this. I know you're looking at serum iron, but I also want ferritin, believe it or not. You know, you have to nudge them along. So I encourage everyone, you know, listening to do that. What about thermography? I know that people have been using thermography for breast and stuff. Is there any validity there?
Yeah, you know, and I think that's another thing where, you know, even before the technology is what we have now, you could still find, especially breast and certain other types of activity, you could find it with thermography. It was done correctly. And I have colleagues who do thermography and are in that world, and the technology they have now is so superior to what they had before. It's like any other imaging procedure. In its context, it can be an incredibly wonderful addition to diagnostic workup. Similarly, and we see this a lot, so we'll get referrals from people, they got breast thermography and there's a spot, you know. It's not acting like cancer, they're not acting like cancer. We'll do the same thing as like a high LDH or CRP. We'll say, well, there could also be inflammatory, infectious other reasons for that hotspot. We will do some presumptive treatment and then do another thermography. If it's still there, then we're going to go to whatever is next. So, but thermography is just like the lab test. The imaging systems they have now are incredible, and there's actually, you know, university-based radiology centers that read them for most places that do it.
Wow!
So it's becoming more in the fold of radiology now than it was. Kind of this, you know, like PET scans are kind of the same way. Or, you know.
I remember it used to be like you kind of had to know someone. There was this gal that came by every other Friday.
It's still kind of, you know, that way, but it's getting more
accepted.
More accepted.
It's funny seeing this field shift since I got in it in 2006. So. Anyhow,
that is true. Yeah, the itinerant thermography people that
you had to look up in the yellow pages, and they were mobile.
Yeah. And I will say I've seen thermography actually help and catch things early on, and then I've also seen, you know, maybe people with less technical acumen or whatever, where there was false positives and negatives like any imaging. And so that's why I say, same as I would say with a PET scan or anything, know who's doing it, get it read by somebody who really knows how to read them, and then put it in the calculus of everything else, you know.
Sure.
Which is,
That's good. A few final questions before we finish up here, but I want to just talk about like big picture preventative strategies. I know detoxification and avoiding exposure to toxins is a big one for you. What about certain immune boosting strategies? We talked about ketogenic diet, intermittent fasting, anything else, mushrooms or any specific herbs that just prophylactically we could include?
Yeah, after the foundation of diet, exercise, all of those things, and I do include what we talked about, which is your thinking patterns and all of that, because that has such an effect on your, you know, on your immune system and your endocrine system. So after that, then yes, live as low toxin lifestyle as possible, but you may need to, as we all really who live in this world do, you may need to do some regular persistent things to depurate, like sweating periodically, making sure you're hydrated, you know, all those good things. So that's something. Working with somebody to see if you have any excessive amounts of toxins, which can be tested for. In our people who survive cancer, we do that on everybody, you know, because it's that big of a deal.
You like stool, whole blood, hair? What do you?
What we normally do is urine for metals, and we now compare it to, the CDC has a database with like 50,000 samples of North American people, and so we know whether they're, you know, is this kind of what everyone else has, or is it like a really high thing? If they're going to get treated for metals, we do additional testing. There are now better, it used to be that these tests were horrible, but there are now better, mostly urine testings for the metabolites of certain chemicals. So if you're eating non-organic spinach and you have a whole bunch of the nasty stuff on there, we can find that. So we generally do a basic screening, and then if those things kind of click over the norms, we'll do a little more investigation. The other that I mentioned earlier, but I found 100% of people who have survived cancer is chronic infections. Those we just check with regular lab tests. It's just the kind of thing nobody thinks to check for.
CMV and some of that?
Yeah, like, so the whole family of HHV, which includes Epstein-Barr and CMV and HHV6, and we check most of that family. The tiny nasty bacteria that like to hang out without symptoms, like mycoplasmas and C. pneumo, and there's others there. There's a bunch, there's sort of a rogues gallery of ones that take advantage of people who've had cancer.
Wow.
And one of the reasons that we check for them, and they're also associated with cancer recurrence, but one of the reasons we check for them is a lot of them like to live in two places. One is in your lymphatic system, which is the last place if you've had cancer you need extra load. And the other, outside of your liver, they all go to the liver, but outside of your liver is the nervous system. And so they can create kind of this chronic background inflammation, which is very bad. So we screen people there. If they're clear, great, not a worry. If they have something, we treat it and kill it.
Is that in the book too? I haven't read it, by the way.
Yeah, we talk about that. We have a prevention and secondary prevention, so we get into that.
So needed.
Yeah, and then there's a number of other strategies. So there's those things, and that's the thing that, 20 years ago, I know I wasn't thinking of, no one else was thinking about, was, oh gee, there's all these little landmines in people that maybe if you don't have cancer, not such a big deal, but if you've had cancer, you don't need the stem cells or the residual cells getting more inflammation from these guys. So there's all that. And then when we make sure there's nothing to clear out, there is super compelling information about mini mushrooms, actually, and incorporating them in your diet is the best thing, and then you can take extra, if you want to. But even like the white button mushroom family, that actually has a lot of anti-cancer activity. I used to think of the white button mushrooms like the you know, kind of like the iceberg lettuce of mushrooms. You know, no, they didn't get any love, but they're like, they have all these potent things, and they're easy to get, and people like them sometimes more than shiitakes or whatever. But mushrooms, super important, and if you just don't like to eat them, you can take them in pill form. One of the things that it was an arm I was involved in of the NIH research, was actually looking at turkey tail mushroom and certain other mushrooms with certain cancers. And in some cases, some of the oddball cancers that just don't respond to anything else would respond to those mushrooms. Wow. Which we weren't expecting, but it was, you know, like, oh, wow, that's cool. So mushrooms can't hurt you. They're a good addition. The other thing is just basic nutrition, especially if you're getting better and you're starting to work out more and all that. You're going to go through more cofactors and other stuff. So just good balanced nutrients. We all need some, and people recovering from cancer, they need good balance there. And then there's other things, like we do in the book, we talk about specific cancers and both the researched specific interventions, but also, you know, between us, we're 40 or 50 years of practice now, just what we've seen patterns of. So we might use more of these type of herbs with this cancer and more of this approach with this other one. Awesome. So we've kind of brought that experience in, and what's been really cool is almost everything that we've seen over the years bear itself out in practice. Eventually studies come out that show that we weren't just crazy and just, you know, having a bystander effect or something. So we, in the book, we have almost 1,100 references. Nice. Which are really, they're not so much for the patient, it's written to patients and families, it's for their healthcare team. If they want to look up something, we make it easy for them. They can find it.
That's so awesome. Yeah, I think a good example of this, what you said, what you found to be true in 20 years of practice is now published research is talking about it. Leaky gut is a good one, where that was poo-pooed, and then instead of, you know, the researchers using the term vernacular leaky gut, they use intestinal permeability. So it's kind of funny to see these things come full circle. Yeah, really interesting. So with mushrooms, my wife and I have found they're so easy to cook with. I mean, they're almost like cooking with meat, you know, and they taste hearty, and it's great diversity. And
it's really awesome, and it's something that you can incorporate into every, I mean, if you want to do every meal. And now there are actually studies that show that people that eat them regularly as part of their diet also have lower rates of certain cancers, et cetera. And then there's the biology studies that show, well, this is mechanistically the stuff in mushrooms that does these immune things. But it's always great if there's stuff, you know, beyond eating in a way that you're not triggering inflammation, if there's things you can put into that diet that are also immune modulating and helping, you know, why not? You're going to eat anyway.
Totally. No, and they do taste good, and for a lot of people that are local, especially in the Northwest for us. One of the controversial nutrients we didn't yet talk about, if we could, you know, kind of as we wrap up here, protein. Very controversial with insulin-like growth factor 1, mTOR, and all that. Where do you stand on this protein causing cancer versus not, and so on?
That's one of those things where I think it depends which end of the discussion you look at. So there are certain amino acids that, if they're really low or they're really high, seem to both be associated with tumorigenesis and things like that. There are certain semi or greatly controversial amino acids that we use in therapy, like glutamine, that, you know, it's going to trigger everyone's cancer and all this. And so the short version of that, because there's been many papers published and I've done reviews on them, is yes, if you have a high glycemic diet and you're swimming in insulin and all the stuff that insulin triggers, glutamine will probably be somewhat or a lot pro-cancer. Especially if you're doing keto or a low carb diet and you're doing the other things to take care of the metabolome, you know, like Naish's book's all about that, the glutamine really doesn't have that effect. Now, we're still judicious, and so we'll use it for treatment and then not give people a ton of it forever and ever. But protein total, and we could go on, there's other amino acids that are very hot button ideas, you know, so you got people reduce, or, you know, a low this diet or low that diet. I think the bottom line probably is a couple of things, because clinically this is what I've seen.
Yeah.
If people, obviously people are cachexic and they need protein, we give them whatever they need, and that's a different issue. But for the general person, I think, because I've seen this with people, so I hope this illustrates it. I had a lady who had completely controlled and basically had a very slow-growing breast cancer. The only intervention she did, she wasn't my patient at the time, but when she came to me, when it kind of got out of the way, 12 years she had done the keto diet. She was way ahead of her time, by the way. Wow. And just some nutrients and other stuff, but basically it was a keto diet and exercise and just basics, right? And she had serial measurements, and and the cancer was very stable. She came to me after about year 11 or maybe 12, and the cancer was starting to not be controllable anymore, and she was on the same diet. And part of the problem in her case was that, and if you go back that many years, it'd be easy to misinterpret. Her keto diet included way too much protein to actually, so like she had kept it under control and she was in ketosis, and then she just fell out at a certain point, and like it just unraveled really quickly, and within 3 years, because she refused, I referred her to others, she refused to go see anyone and all that. Mm-hmm. And within 3 years, she had passed away. But the one thing in kind of deconstructing her case, because we try and learn from things, was her protein intake levels were way too high, even though she had kind of maintained keto. But when it clicked over, I think that what went on is there's so many of the amines that become glucogenic amines, mm-hmm. and I think it just started to kind of come around the back door and be a problem. So what I take away from that experience, so that's the most profound experience I've had with seeing somebody over a 15-year period do something, is if you're doing a low-carb keto-N type of a diet, you do have to be careful about the protein sources. But I think the other thing that, which is always a thing with keto diets too, and this is something Dan Agostino and I talked a lot about at our conference and just privately, is the source of the protein that you have. A lot of protein sources are very good vectors for a lot of chemicals and toxins. Yeah. And so what we don't know, because there's little to no research parsing that out, is it the fact that there was this much protein and maybe it did do glucogenic stuff and all that, or is it that the protein you've been eating has been dosing you with junk, that your body doesn't need? So that's a part of it too. Yeah. So I think it's the amino thing and the protein thing, I think is much more complex than what people make of it. And I think you have to be judicious with proteins and aminos, and because you need them, but you don't need too much. Mm-hmm.
And then you need to take into the consideration the potential toxins that sources bring in.
Yeah, you have to be really big, because you look at whether it's meat or even so, a lot of soy sources actually have a lot of heavy metals and other stuff in them, and so you just have to back up and say, okay, I'm going to eat X protein. I got to find clean protein. It's like that. That's a real great carrier for toxins.
Totally. Yeah. People don't realize that. I remember there was a study actually at the Russian, no, not the Russian, it was the something West Delta in China, looking at heavy metals in pig, chicken, and beef. And actually, beef had the lowest amount, and pig and chicken had really, really high levels of persistent organic pollutants, endocrine disruptors, which affect the immune system and bring us back. So good point. And so, but there's a lot of people, they're so focused on the macros. Well, what's low carb? What do you mean? Well, yeah. So there's that new level of complexity that you just introduced, which is great. Yeah. All right, well, this has been an awesome chat. We have 3 final questions we ask every guest on the show. All right. First one is your morning routine, or maybe we can kind of reframe it as an ideal morning routine for both productivity enhancement and cancer prevention. What would a few things people could do every day to prevent cancer? This has been an evolution over time, and honestly getting to the point where I've seen so many people who have cancer, you start to think, none of us know which end of that spectrum we're on. So what's the best things I can do? So outside of what I eat and all that,
One of the things that has helped me the most, and time will tell whether it prevents cancer and all that, but is the mind game. And so starting the morning, not becoming involved in the mad rush to distraction and the to-do list and all the stuff we have to do every day to make money and get along in life, but actually having a bit of time where I can just center to, things are okay, this is going well, or whatever I need to think about. So that kind of centering practice, that has made a huge change just in the way I deal with the rest of the day. But I think that there's enough research to say, at least on the psychoneuroimmunology end of the spectrum, that's such a cornerstone, and what I do now is and this is something with the traveling that I have to keep doing, I have that in the morning, and then I try before I go to bed at night to kind of have an ending to that, and kind of deconstruct the day, etc. So I think the mind game is huge. If schedule allows, I normally try and do my exercise in the morning as well, so to kind of keep that rolling so the brain gets straight, then the body does its thing and all that. And then hydrating, which is something I've always been terrible about, but most people are, so I don't feel too bad. But like with intermittent fasting, most of the side effects that I've gotten once you get past the idea of not eating for certain time periods are just, I'm just dehydrated, and your body doesn't know why, so it makes you hungry or have a headache or whatever. So I think that, like feeding my cells with some water in my brain and then getting my metabolism moving has been the best thing, really. And we do that with patients, and we're sensitive to the fact that, hey, if you're just coming off chemo, you're not going to go out for a run, probably,
Right.
So it might be standing up today, or it might be walking to the bathroom and back or whatever. Just get it going. But that's kind of my 3 that I try.
That's awesome. Yeah, having that reflection moment in the morning. Some people have the TV in the bedroom, they got CNN going right when they wake up, and they wonder why they're anxious or stressed. I mean, there's a...
Or our phones or our way, we got a million ways to get information
the
that we
phones.
don't need right away in the morning.
Yeah. All right, so if there wasn't one herb, nutrient, or botanical that you're stranded on a desert island, Woodby Island maybe, for example, vitamin D, omega-3s are covered,
all right.
What anti-cancer, longevity-enhancing nutrients coming with you?
If I could only pick one, honestly, I would pick curcumin. And it's partly because there's probably just the most data on that. But here's the thing with curcumin that I think is really magical. And let's say you took curcumin away, it would probably be mushrooms. But curcumin, when you look at it, if you look at the cytokines that it levels out, so all the triggering molecules and all this stuff, everything that it does basically sends you in a direction away from cancer triggering, away from tumor stem cell triggering, all that stuff. It basically all goes in that direction. So it's not like it's a stimulant to your system or whatever. It just takes you back to the 0 level that then your body can deal with things that come along. So I would say curcumin, and if the curcumin supply dried up, it would probably be mushrooms.
Yeah, love it. There's so many different forms of curcumin, BCM95, biopertin enhanced. What's your perspective? What do you...
We've experimented a lot with it, so just to really short version of the story. One of the things that we did towards the end of the research study is we actually did very high dose intravenous curcumin with salvage patients, meaning nothing worked.
Wow.
Chemo would stop working, and these are stage 4 cancers everywhere. And out of 15 people that we did that with, and it's not available right now, so you can't run out and really get it, but it's also very expensive, so it's good it was a trial. But out of the 15 people, we actually had 5 people where on imaging they had regression of metastases in their bones, and like to the degree the radiologist said, this must be chemotherapy effect, and it was actually high-dose curcumin. Now, what that really proved was if we marinate somebody with a lot of cancer, it actually will shut off the triggers for metastases. So 5 out of 15, the others, we had other gains, that we had, and these are like proven on imaging. You can't really do that with oral curcumin, but my point with curcumin on the oral side is we then started looking at, okay, which ones absorb better and all of that. without doing blood studies, that's a toughie. But what we did was we took people who had non-cancer inflammatory things where they knew whether they were in or out of pain, so our arthritides and stuff. And we just tried different curcumins, and what we kind of boiled down to was I was get the acronym, the BC one.
BCM95, yeah.
That one was right at the top of the response. It and now there's more than one manufacturer that has it and all of that. So that kind of became our go-to. Nice. There's also a powdered version that is really good, and it's got different adjuvants. It uses like coconut and some other stuff to help it absorb. That one works really, like that one you'll actually see come out in people's sweat, so you know it's absorbing.
Is that the one made locally?
It's,
okay.
Ayush Herbs. Yeah.
Cool, that's good to know.
That's a super, and that's also really good if they have GI problems from anything, because it's going to treat their GI really well. So those are our two real go-tos.
Yeah.
But there's many good ones now.
Well, I mean, the BCM95, I'm a huge fan of that because it's the closest to whole food that we have, using the turmeric essential oils. The other ones, you know, everyone was hot on Mariva for a while, but it's a very small fraction of curcumin and mostly soy lecithin. Yeah. Anyway, awesome stuff. All right, so final question here. You're with a politician, parliament member, someone that is going to influence the masses, right? And they're going into a meeting and they say, Dr. Anderson, what's one thing about cancer I should know about that would help with prevention? You know, I'm going to go into a meeting here and we're going to talk about lifestyle stuff. What's the one thing on a big picture level that you would tell them?
What I would tell them is it kind of winds back to our initial discussion. If you can get people to do the things that bring their metabolism back to its intended balance, and of course then that includes more than one thing, but that's all the basics plus everything, that is the most important thing probably to keep people from developing cancer. Now that also encompasses, that means that there's less toxins, less infections, less brains, but really, if you bring our metabolism back, yes, there's some cancers that don't care what your metabolism's doing, right? But many of the cancers that we see now that are just kind of going rampant are because we're just never in balance and we're never there.
So to summarize, like, don't give the cancer cells any opportunity. Right. Play good offense.
Yeah, you never know when they're there. We all have some. Don't give them any opening in the door. And you know, 50, 70 years ago, you had to open the door wider. You know, now it's like, don't even open it a crack if you can.
Your margin for error. Yeah. You could have went to In-N-Out Burger back in 1990, but not now. Yeah.
Keep that low. Do that very rarely.
Yeah. All right. So we got the book, Outside the Box Cancer Therapy. So it comes out April 24th. Well, it's out now. So
so some bookstores get it early.
Really awesome book.
And
I'm excited to read this.
It's you can get it online or at Barnes & Noble or other bookstores.
Yeah, it's fantastic. Cool. Is there a book website? I mean, if people just...
Yeah, so you can either do the general search like people do on Barnes & Noble or Amazon. There's also a website that has information more than is on there than is on those sites. It's just drabooks.com, so drabooks.com.
For Dr. Anderson
and it's
books?
got a summary, it tells about the authors, all of that.
Awesome.
So if people want to give it a little look-see first.
Yeah.
And it's Amazon because they're not releasing, they have it, but they're not releasing it quite yet. They haven't done like the open the book and read it and stuff yet. But Barnes & Noble did because they have it apparently.
Yeah, yeah. Well, that's funny. Yeah. The publishing world, it must be competitive.
I do not understand that.
Yeah. Awesome. Yeah. Well, thanks for this conversation. Thank you. Great work. It's been a lot of fun getting to know you over the years, and I want to thank you guys for tuning all the way in. Thanks for watching it this far. Definitely go out and check the book. I'll put a link in the YouTube description below, and if you like this video, please hit that like button. Follow Dr. Anderson over on social media. I'll put the links there as well, and have an awesome day.